Hello, everybody. Hello, everyone. I hope I'm audible and visible, and my presentation is visible to everyone. I hope you can all see my presentation, and I'm audible and visible to every one of you. Okay, so today's short session is a recall of recently concluded INI-CET exam, and these questions have been recalled by students from their memory. So there might be a slight difference in the language of the questions and also in the options that have been recalled. But overall, this is just meant to give us an idea about what are the types of questions that have been asked. And since many of you, you will be preparing for the NEET PG of this year, or you might be aspiring for the next PG, or you may be students of FMG. So this is just like a basic idea about what kind of questions are being asked nowadays, and how we should approach these questions. That is the basic idea of this short session that I'll be doing. Right, so let me just come on. I have a few questions. Of course, the entire set of questions with perfect recall is not possible, but then a basic idea about the nature of the questions is what we want to give. Right, so let me go to the first question. See, this question says that look at the 9-gaze photograph of this patient of stroke and ascertain which is the nerve that is being affected. I'll come to the photograph because it's a big photograph. I've put it in the next slide. So basically, the photograph that has been given to us, we have to look at the 9-gaze photograph and of a patient of stroke and ascertain which is the nerve that is being affected here. So the options given to us are third, sixth, fourth, and seventh, right? Now let me first show you the photograph. So let's look at this photograph. So suppose this is the photograph that has been given to us. It's a 9-gaze photograph. Now, when you look at a 9-gaze photograph, see this central picture, this is actually the primary position. This is the primary position. That means this is when the patient has been asked to look straight. This is your primary position. And of course, from common sense, you can understand that this is when the person looks up. This is the patient in up gaze. This is the patient in down gaze. This is when the patient is looking to this side. The patient is looking to this side, right? Patient looks up, down, this way, this way. And this is, see, for example, this is right and this is left, right? So this is when the patient is looking to the up and right like this. Dextro elevation, dextro depression. Here, levo elevation, levo depression. So this is up and right. This is down and right. This is up and right. This is down and right. Similarly, see here you have up and left and it is down and left. These are the 9 gazes, and the central photograph is the primary position, right? So the central photograph is the primary position. The picture on up, this is when the patient is looking straight up. This is when the patient is looking straight down. This is when the patient is looking to the right. This photograph is when the patient is looking to the left. Now this is say up and right. This is down and right. This is up and left, and this is down and left, right? Now, when I look at the photograph, I have to first look at the primary position. So from this photograph, what do you see in the primary position? The first thing that strikes us is that in the left eye, there is a ptosis. There is a ptosis in the left eye, right? And what is the position of the eye here? See, look at the position of the eyeball. The position of the eyeball is say downwards and it is outwards. So from the primary position, you make out that there is a ptosis. From this photograph, we make out that there is a ptosis, and the position of the eye is down and out. It is down and out. There is a ptosis and the position of the eye is down and out. Now look at the movements. Look at all the movements on the right side. See, look at all the movements on the right side. See, this is your right side and this is your left side. So if you look at all the movements on the right side, when the patient is being asked to look to the right side, see, this left eye is not moving at all. It's not moving at all on the right side. It is not moving up also. There is the elevation is affected, the depression is also affected. So the medial movement is affected, the elevation is affected, the depression is affected. But see, when the patient is asked to look to the left side, this abduction is taking place normally. So look at the abduction here. The abduction is taking place normally for the left eye. So if you look here, the patient is not able to elevate the left eye, he is not able to depress the left eye, he is not able to adduct the left eye, but he is only able to abduct the left eye. So only the abduction in the left eye is normal. So this is basically a case of third cranial nerve palsy. So the affected nerve is the third nerve. So how do we come to this conclusion? So for that, let us just quickly go over what are the muscles that are supplied by the third nerve. What are the muscles that are supplied by our third nerve? See, the third nerve, it supplies the LPS muscle, the levator palpebris superioris, which is whose function is elevation, right? Whose function is elevation. So therefore, when there is a palsy of which affects the LPS, there is going to be a ptosis, and it is essentially going to be a severe ptosis. Why? Because the LPS is the main elevator of the lid, right? Next, the LPS, it supplies, the third nerve, it supplies all the extraocular muscles. It supplies all the extraocular muscles except whom? It does not supply the SO, that is the superior oblique, and it doesn't supply the LR, that is the lateral rectus. So therefore, when there is a palsy, then what's going to happen is that all the muscles, extraocular muscles, will be paralyzed excepting the SO and the LR. Now see, the SO is a depressor. The SO is a depressor and the LR, this is an abductor. So when there is a complete third nerve palsy, the only movements, the main movements that are left in the eye are the movement of the SO, which is depression, and the movement of the LR, which is abduction. So what happens to this eye is, the eye is depressed and it is abducted, meaning the position of the eye is down and out, as you saw in this picture. So see, in this picture, what did you see? You saw ptosis and you saw that the position of the eye is down and out, right? So this is third cranial nerve palsy. Now apart from that, the third cranial nerve, it also supplies the sphincter pupillae muscle. It supplies the sphincter pupillae muscle. So therefore, there is going to be the constriction of the pupil will be lost. That is, you will end up with a dilated pupil. You will end up with a dilated pupil, and it also supplies the ciliary muscle. So the ciliary muscle is responsible for accommodation. So in third nerve palsy, there is going to be a loss of accommodation. There is going to be loss of accommodation, right? So these are basically the features of third cranial nerve palsy. So there is going to be a ptosis, the eye is going to be down and out, there is going to be a dilated pupil, and there is going to be a loss of accommodation. So in this patient, we see that there is a ptosis, the eye is deviated downwards and outwards, and all the movements are lost in the left eye. So see, I have pointed out the left eye for you. If you look, all the movements in the left eye are paralyzed except for abduction. So see, when the patient is looking to the left side, the left eye is abducting. But when he is elevating or depressing, or he is looking to the right side, his left eye is not moving at all. So this is a case of third nerve palsy. But if you look at it here in this picture, if you look at the picture carefully, you will see that the pupil, I told you, in a third nerve palsy is supposed to be dilated. But here, see, the pupil is not dilated. So this is basically a pupil sparing third nerve palsy. This is a pupil sparing third nerve palsy. Now, where do we get a pupil sparing third nerve palsy? Where do we get a pupil sparing third nerve palsy? A pupil sparing third nerve palsy. This is seen in case of microvascular infarcts. So microvascular infarcts, which is seen in case of say diabetes, hypertension, etc. So microvascular infarct, that is if there is a microvascular infarct and due to say diabetes, hypertension, etc., then you will get a pupil sparing third nerve palsy, right? But if it is a pupil involving third nerve palsy, then it is going to look something like this. So see in this picture, what do we see? We see that there is a ptosis. We see that the position of the eye is down and out. The position of the eye is down and out, and also you see that there is a dilated. There is a dilated. So if there is a dilated pupil, this is a pupil involving third nerve palsy. And if you have a patient where the pupil is not involved, then we are going to call it as a pupil sparing third nerve palsy, right? So this is the one of the questions that was asked this time in the exam. Now let me go to the next question. The next question again was relatively simple. So this is the question where we have been given the visual field defect of a patient and we are asked what is the site of the lesion. So see, this is the visual field defect of the patient and see they have labeled it as the right eye and the left eye. So this is the right eye and this is the left eye. So whenever we get this kind of an image, see we have to first understand which is temporal and which is nasal. So temporal, nasal. For this eye, this is nasal and this is temporal. Right? So what is this field defect basically? What you see is that the nasal field of the left eye, see look at the picture, the nasal field of the left eye and the temporal field of the right eye, they are affected. It is the nasal field of the left eye, the nasal field of the left eye and the temporal field of the right eye are affected. So this is a homonymous hemianopia. Homonymous hemianopia. But if you look carefully at the homonymous hemianopia, you will find that see this central area is not black. It is spared. So this is a homonymous hemianopia with central or macular sparing. This is called as a homonymous hemianopia with central or macular sparing. Right? Now see, this is not that difficult. What is difficult is to understand the right and the left. Now the question is, do we call this as a right homonymous hemianopia with macular sparing or do we call this as a left homonymous hemianopia with macular sparing? Now the answer is, look at this. If you look at this image, see the field defect is towards the right side. The nasal part of the left eye and the temporal part of the right eye are affected. So this field defect is towards the right side. So we have to call it as a right homonymous hemianopia with central or macular sparing. It's on the right hand side, right? So therefore, the site of the lesion is the left occipital lobe. The site of the lesion is the left occipital lobe. So this is a right-sided homonymous hemianopia with central sparing. That is why the answer is the left occipital lobe. Right? But suppose they had given us something like this. See, if we say that this is the left eye and this is the right eye, and they had given us something like this. Sorry. If it is the left-sided field that is affected, that is, we have something like this. That is, this part of it is affected. This would be a left homonymous hemianopia with central or macular sparing. So if we draw it like this, see here in the picture, they have actually made it easy by giving us the right and the left, which is the right and which is the left. So if we have something like this, we have the right and the left given to us here in this picture. I am writing it exactly the same way we have the picture. So this would be called as a left homonymous hemianopia with macular sparing. And then our answer would have been the right occipital lobe. But what has been given to us here is the field defect is towards the right side. So it's a right homonymous hemianopia with macular sparing. And so our site of lesion is going to be the left occipital. right? Now just to finish off the discussion, see for optic tract, if the answer is optic tract, it is going to be a simple homonymous hemianopia only. There will be no central sparing. And also if it is a optic chiasma, all of you know that it's going to be a bitemporal hemianopia. So for optic chiasma, it is bitemporal hemianopia. And for optic tract, it is homonymous hemianopia but without the central sparing. Right, for homonymous hemianopia, but there will be no central sparing if it is the right optic tract. Okay, so this was actually a simple question. The only problem in the question, I would say, or the difficult part of the question is to understand whether we should call it as a right homonymous hemianopia or left homonymous hemianopia. So this is a right homonymous hemianopia. Just remember that the blackening or the darkening is towards the right side. So it's a right homonymous hemianopia with central sparing. So we have to call it, the site of the lesion is the opposite side, that is the left occipital. Right? Let's go to the next question. The next question is actually a very, very simple one. What is the most common route of spread of retinoblastoma? The retinoblastoma, this is, all of you know, it is the most common intraocular malignancy in children. It is the most common intraocular malignancy in children. And what is the most common route of spread of retinoblastoma? Most common route of spread of retinoblastoma. Now this is something which we have to learn. This is the optic nerve. It is direct spread to the brain via the optic nerve. That is the most common route of spread of retinoblastoma. Right? So this was actually an easy question. The most common route of spread of retinoblastoma, that is via the optic nerve. It spreads to the brain. Now, taking the opportunity of this question, let us just quickly revise a few salient points about retinoblastoma. Now, just regarding the treatment options for retinoblastoma, I just want to tell you a little bit about the treatment options for retinoblastoma. This is the question that was asked to us was pretty simple. The most common route of spread of RB, and that's the optic nerve. Now, for retinoblastoma, if you are asked regarding the treatment options for retinoblastoma, what will you say? What are the treatment options for retinoblastoma? Suppose they tell us that there is an intraocular retinoblastoma. There is an intraocular retinoblastoma, but it is small. That is less than 50% of the globe is being occupied. Then what is going to be your treatment option? And if they say that it's intraocular, but it is occupying more than 50% of the globe, then what will you mark as the answer? See, this has come many times in the past, so I just thought that we'll quickly go over it as a flowchart. See, if the question says intraocular retinoblastoma and it is occupying more than 50% of the globe, then the answer that you have to mark is enucleation. Enucleation means removal of the globe with a portion of the optic nerve. Removal of the globe with a portion of the optic nerve. But if they say that it's an intraocular retinoblastoma, but it is small, then you have to mark focal therapy as your answer. Focal therapy means that you treat just the mass, but you do not remove the eyeball. Right? So if they say that it's intraocular, meaning it is confined to the globe, but it is large, then you mark enucleation as your answer. But if they say that it is inside the eyeball, but it's small, then you mark focal therapy as the answer. Now, another set of questions that they give is, they say that there is a retinoblastoma, but with intraorbital extension or locally advanced retinoblastoma. Intraorbital extension or locally advanced retinoblastoma. Now, locally advanced retinoblastoma is generally inoperable. So, the first few, the treatment is a first few cycles of chemotherapy. And once it becomes locally resectable, then you go for enucleation and then you go for orbital radiotherapy if needed. If you go for orbital radiotherapy if it is needed. So this is what you have to mark if you get retinoblastoma with orbital extension. But if you get a question that is the last option, that is retinoblastoma with METs, if they say retinoblastoma with METs, then you mark palliative chemotherapy as the answer. So this is the basic flowchart or the basic way in which questions are asked from retinoblastoma treatment. See, they have once asked about the spread, now they can ask this. Right? So see, let's just go over this quickly. For intraocular retinoblastoma, if they say that it's a large mass, then we mark enucleation as the answer. But if they say it's a small mass, if the question says, then we mark focal therapy as the answer. Now, if the question says that it's retinoblastoma and it has an orbital extension, that's it's a locally advanced retinoblastoma, then the first option is to make it operable by a few cycles of chemotherapy, then enucleation, then orbital radiotherapy if needed. And if the question says that it's RB with meds, then the answer is palliation, that is palliative. Right? So now let's go to the next question that we have. Right. This is another slightly difficult question which was asked this time, that a patient is presenting to us with pain and redness in the right eye, and on examination there are keratic precipitates and cells and flare in the anterior chamber, and at the same time the IOP is around 40 millimeters of mercury. Now, which of the following anti-glaucoma drugs should not be used in this condition? Now, we are not exactly sure whether these were the options and this exactly was the question, but it seems from what students have recalled that this probably is what was asked. So, if this is the question, then what does it mean? That the patient has got a painful red eye, there are keratic precipitates with cells and flare in the anterior chamber. So, there is uveitis, right? So, there is uveitis, and there is also high intraocular pressure. So this is uveitis, and there is also glaucoma, which we will call as a uveitic glaucoma. We can call it as a uveitic glaucoma. So the question says that which of the anti-glaucoma drugs must not be used in this condition. Now the options are mannitol, beta blockers, carbonic anhydrase inhibitors, and PG analogs. Now for this question, the answer should be prostaglandin analogs. The answer should be prostaglandin analogs. Now, why are we choosing PG analogs as our answer? Let us just quickly go through which are our PG analogs. See, all of you know which are the PG analogs that are used in glaucoma, the prostaglandin analogs. The prostaglandin analogs that are used are, see, we used latanoprost. The common ones are latanoprost, travoprost, and bimatoprost, right? Latanoprost, travoprost, and bimatoprost. These are our PG analogs. Now, their mechanism of action is they increase the uveoscleral outflow, and that is how they help in decreasing the intraocular pressure. They increase the outflow through the uveoscleral pathway. They increase the outflow through uveoscleral pathway. They increase the outflow through the uveoscleral pathway. That's their mechanism of action. Now, their important side effects are, of course, like all anti-glaucoma drugs, they cause allergy, but they cause an increase in inflammation. They cause increase in inflammation, and they also have an important side effect, that is they cause cystoid macular edema. They cause cystoid macular edema, and they are also known to increase the intraocular inflammation to a certain extent. So therefore, in a canine eye which is already inflamed, that there is uveitis, these PG analogs, they will increase the inflammation and they have the propensity to cause cystoid macular edema. That is why PG analogs should not be given in uveitic glaucoma. They are known to increase, they are believed to increase, I would say, the intraocular inflammation, and they also cause cystoid macular. Right? So that is why we are not giving it in a patient who has got both uveitis and glaucoma. And just to complete the list, these drugs are also known to cause hypertrichosis, and they also cause iris pigmentation. So these are the side effects of this class of drugs. But the side effect that becomes important in this question is this, that is cystoid macular edema and increase in intraocular inflammation, which makes it unsuitable for a case of uveitis. Right? Sure. Let's go to the next question. Now, the next question was actually an easy question. It says a patient presents with pain and redness in the right eye following trauma with vegetative matter. And on examination, there's a corneal ulcer with a hypopion, and the ulcer is dry looking with feathery margins. So what should be our diagnosis? So see, this question has got two important clues, that there is a corneal ulcer which is preceded by a trauma with vegetative matter, one. And second, there is a dry looking ulcer and there is feathery margins. So obviously our answer is going to be fungal corneal ulcer. So here, because they have given us all the important points that are related to a fungal corneal ulcer, the important points that are there generally in fungal ulcer is, the first is what's given in the question, that is trauma with vegetative matter. Second point that is generally given in the question is the presence of satellite lesions, that is multiple ulcers. There is one large ulcer and surrounding it there are multiple smaller ulcers. Then you have feathery margins as is mentioned in the question. Then you have a dry or leathery surface. Dry or leathery surface. These are the things that are generally mentioned in the question. And if there is a hypopion that is mentioned, then the hypopion, they might mention that it is a fixed hypopion. And they may also mention that it is non-sterile. It's a non-sterile and fixed hypopion. Non-sterile obviously cannot be seen clinically, but fixed hypopion, yes. It's a thick pus, fixed hypopion. These are the things that they generally mention in a question with fungal. Right now, taking the opportunity of this question, I just thought we'll just quickly go over a few images. So if you look at these two images, say suppose if we are given image number 1 and image number 2, and instead of all this story that was given to us in the question, suppose they gave us just the image and said that this is the image of a patient having corneal ulcer and we have to diagnose it as bacterial or fungal. What would you call picture number 1 and what would you call picture number 2? See, in picture number 1, there is an ulcer, but look at the margins of the ulcer. See how the margins of the ulcer are. They are not well defined. They are like feathery, right? So this picture, it has got an ulcer with typical feathery margins. So picture number 1, if we get in the exam, we are going to call this as a fungal corneal ulcer. We are going to call this as a fungal corneal ulcer. But if you get picture number 2 in the exam, so look at this ulcer here. There is a single ulcer here also, but look at the margins of the ulcer. This has well-defined or sharp margins. So this has got sharp, or we can call it well-defined margins. The margins are not feathery, well-defined or sharp margins, and therefore we are going to call this as a bacterial corneal. Right? So instead, this time they have given us the theory in the question. Next time they might not do that. They might just give the picture and they may ask us to identify. Right? Now another picture that I want to show you is, suppose they give us this image and they ask us what kind of ulcer this is. So in this picture, see, these smaller lesions. These are your satellite lesions. So there is one central large ulcer with multiple small surrounding ulcers or satellite lesions. So this also we must call as a fungal corneal. Right? So the questions, these are a few of the questions that have been recalled by the students. So there was one question on cornea. There is one question from glaucoma and uveitis. There was one question from retinoblastoma. There were 2 questions from neuro-ophthalmology, one from this visual field and the other was from the third cranial nerve palsy. So these are the questions. These are few of the questions that have been recalled, but I must say that the questions this time were not very difficult questions. They were relatively straightforward and also from the more important topics. Right? So this is what I had for you in this session today. So we are, to help you prepare for NEET PG and also for next 2022 exam or for FMG exam, we are having a lot of classes on our we are having a lot of special classes and also a number of classes on our Plus platform. So if you want to enroll for the Plus subscription, you can use my code DOCSUDHA. This is my code, and this Plus subscription entitles you to our daily live classes, our structured courses, live tests and quizzes. And you can also enroll for the Iconic subscription using the same code, and this entitles you to get the best of both Unacademy and PrepLadder. Now, on this platform, we are running courses which are targeted to exactly whatever exam that you want to prepare for. So we have this Target Next 2022 batch, which is starting from this 28th of July. It's a June to January evening batch, live interactive classes with in-depth subject-wide preparation, and we will be having test and discussion sessions, doubt clearing sessions, and we will be also having integrated approach for the topics, that is we may be having dual educator sessions also, where one particular topics will be discussed from the perspective of two clinicians with two different specialities. And in case you miss the live sessions, the recorded sessions are always available for you. And also the PDF notes for the sessions are going to be provided. So this is a Target Next 2022 batch. Also, there is a Focus FMG batch for those of you who are preparing for the FMG exam. And this also begins from 28th of July. It's a 6-month batch. Again, we'll be having an integrated approach, in-depth discussion and test and discussion sessions. Right, so you can use the code for the Iconic subscription or for the Plus subscription, and so that you can avail the best benefits that are available on this platform. Right, so thank you everybody for attending the session. You can follow me on the Unacademy app, and I will be having a few special classes this month and also the next month for those of you who are preparing for NEET PG, where I will be discussing MCQs of the NEET PG pattern, image based and case based MCQs. So you can follow me on the Unacademy app and you can join me for the special classes. And as I told you, if you want to enroll for the Plus subscription to take the benefit of all the classes and courses that are going on in the platform, you can use my code docs. So thank you everyone, and hoping to see you in the other sessions also. Bye bye.